almost through, but now it's 5:30.
There we go.
Yeah, it's 5:30.
All right. Good evening, everyone. Thank you for coming out tonight. Today is Wednesday, March 28th, 2018, and it's 5:30. I'd like to call to order the meeting of the Central Health Board of Managers. Tonight's agenda will be taken in the following order. Agenda item number 8, 1, 2, 3, and then the consent agenda, and then items 5, 4, and 8, and 9, sorry. And I'd like to use my new gavel that my wife just bought me to call the meeting order. Thank y'all.
Matches your top. It matches your shirt.
All right. Citizen communications.
So we have a couple of people, I think, who are new to citizen communication, so I just want to go over the rules. Any person may speak during the citizen communications portion of the Central Health Board of Managers meeting. In advance of speaking, an individual must complete a sign-in sheet. We ask that you provide a telephone number and email address. The chairperson or presiding officer will call speakers in the order in which they are listed on the sign-in sheet. Each speaker has a limit of 3 minutes. Each speaker may address the board only one time during any particular citizen's communication. The speaker may not donate his or her 3 minutes to any part or any part thereof to another speaker. The speaker does not have the right to speak if he or she signs in after citizen communication or the hearing is closed. And the chairperson or presiding officer may impose additional guidelines at the time or manner of the speaker's presentation to ensure the efficient and effective conduct of the meeting, and due to the restrictive nature of the Open Meetings Act and to fulfill proper notice and meeting requirements, the board is restricted from discussing any item that is not posted on the agenda for that meeting. Therefore, the board may be unable to address your comments, and thus citizen communication is most usually a one-way communication vehicle. However, a Central Health staff member may follow up with you regarding the topic of your communication as appropriate.
Thank you, City. First on board is Mr. Burton, Ted Burton, Central Health.
Good evening. I'm Ted Burton, Vice President of Communications here at Central Health. I'm going to try to raise this. 2 items. First, I'd like to introduce Anastasia Mitchell, our new multimedia content coordinator. Anastasia joined us about a month ago. She was the multimedia content coordinator at the Better Business Bureau of Heart of Texas. She and I have 2 things, at least, in common. She's a journalism major graduate from the University of Texas, and she also is a native Austinite, graduated from McNeil High School.
Wow.
So if you follow us on social media, and I really hope all of you do, you've already seen some of the fruits of Anastasia's labor. She's helping us generate video and other types of content for our social platforms and also for our website. So I wanted you to see her because she is going to be reaching out to you, I'm sure, at some point to ask for an interview or information. So I wanted to welcome you to our team.
Thank you.
Welcome. And next, I want to quickly update you on some of our community engagement and outreach activities. On Monday, March 19th, we held a community conversation here in this room from 5:30 to 7 o'clock about the Germain Performance Review, and we wanted to gather community input and comments. Germain first provided a brief overview of their recommendations, and then the attendees split up into 4 groups that were facilitated, where they discussed particular recommendations in that performance review. We reached out to 6,911 people and invited them to the event. The event was shared on Facebook and Twitter and our website. We also distributed flyers, both in English and Spanish, to community organizations throughout our area. All of the promotional materials were offered in English and Spanish. We had 64 RSVPs and 45 participants came, representing 30 different organizations. Some examples include Any Baby Can, LULAC, People's Community Clinic, and Travis County Health and Human Services. Next, Central Health is compiling a report synthesizing the feedback, which we will prepare for you, and then of course we'll provide to the public on our website, etc. Next week, we have 2 more community conversations. First, on April 3rd, from 6:30 to 8 o'clock at the Central Health Southeast Health and Wellness Center. We will do a community conversation about the 2019 Central Health Work Plan. The format will be similar to the one that we used last Monday night. And then on April 5th, which is Thursday, from 6:30 to 8, we have another community conversation about the work plan at Lanier High School. In terms of how we promoted this to the community, We've emailed more than 6,000 people. We'll send a reminder email tomorrow. It's placed on our website. We've been posting on all of our social media platforms. We placed ads in the Villager and El Mundo. Our outreach staff has been distributing flyers at the events that they're attending throughout the week. And Community Impact also wrote an article about last week's meeting and promoted the upcoming meetings in their news article. Thank you very much.
Thank you, Mr. Ricketts. Thank you. All right, next will be Mike McKinnon from Central Health.
Good evening, Board. Mike McKinnon. I'm the Communications Solutions and Innovation Manager for Central Health, and I just wanted to update you on a couple of briefly on a couple of topics. One, we are broadcasting tonight's meeting again, as we did Budget and Finance last week, on TCTV, which is the county's cable public access channel. We did have some issues last week. We think we might have those resolved. So tonight will be hopefully the final experiment in this broadcasting solution before we're actually able to really start publicizing this. But just a note, if you are watching this historically online and you do have cable and live in the city of Austin, then fingers crossed you'll be able to now watch the meetings live on TCTV, which I believe is historically channel 17. So barring any disasters there, that will be the practice going forward. We'll continue live streaming to our website and to our YouTube channel, but also simulcasting on cable. And the one other thing that I wanted to mention, you may notice that there is a reformatted communications and outreach report at your place. It's been condensed from what you're used to seeing. Hopefully it will be more useful to you as it's more bullet and dashboard oriented. There's maybe a little bit more information for the data nerds amongst you. As kind of a corollary to that, I believe the staff has also gotten in touch regarding the new Board of Managers message board that is on the website. This is something that the Board of Managers will be able to use in conjunction with staff to keep up with meetings and notes and related information. This information the board report will be expanded on there, so there will be even more data regarding the metrics that we collect, particularly as it pertains to digital communications or social media, that sort of thing. So you'll be able to take a deeper dive if you wish into that. Hopefully that will be a function of the website that you'll find useful. So if you have any questions, that should probably be directed to Emily or Stephanie. Anyway, if there are any questions about that, feel free to contact Ted or me, and we'll help. Thank you.
Thanks, Mike. Our next citizen is Joshua Aoli.
Yes, sir. My name is Joshua Ollie. I just wanted to come before the board tonight to share some of my personal experience with Central Health. Over the course of the past year, I had personal experience struggling with homelessness and with mental illness. I've been diagnosed with acute PTSD, acute major depression, and agoraphobia. I found myself homeless at the end of November of 2016 and struggled with homelessness for some time after that. At one point, I found myself in a suicidal state and ended up at Dell Medical Center seeking help with stabilization, seeking hospitalization. Ultimately, after a rather cursory medical checkup, I had a very brief conversation with a psychologist there who directed me to a facility. I got a courtesy cab ride to a facility called NA24, or Narcotics Anonymous 24. The ultimate result of which was that I was homeless again within 2 days. I was ultimately, someone at NA24, a person there let me stay at their house for a night, but I did not receive any of the resources I needed at the time. I felt strongly that I needed hospitalization and stabilization. I wasn't going there to try to game the system or to seek out somehow to seek out housing. I was seeking hospitalization and stabilization so that I could then find the resources I needed to prevent further homelessness. I think in a case like mine, where I had PTSD and agoraphobia, my mental health and my homelessness are directly connected. And so I just want to encourage the board to view hospitalization as sometimes a positive outcome for those who are homeless, and something that may be absolutely necessary early on in the treating of homelessness. I would encourage the board to advocate for their patients just as much as they advocate for the taxpayer dollars that are going into treating the patients. And so I believe that's all that I have to say today, unless anyone has any questions for me.
Thank you, Joshua.
Okay, thank you very much.
Thank you for coming.
Thank you.
The next one is Zach Webb.
Hi, I'm here to offer comments on an item on the consent agenda related to ECHO's Pay for Success proposal. As a concerned citizen, I request respectfully that you pull the item from the consent agenda for discussion and vote against its approval. At the very least, I believe your fiduciary duty to be good stewards of public tax dollars demands that you table any discussion until at least the next full board meeting so that you may have the community discussions and be provided the information that you will require to make a responsible decision. I must say that I'm a longtime friend of the homeless and fully support the city and county using their resources to develop more supportive housing. However, Central Health, as distinct from the county or even city, has a specific statutory purpose to furnish medical aid and hospital care. Your spending and your tax revenue are bound by this mission, and other governmental entities cannot raise or spend the taxes needed to provide that direct clinical care. So when you branch upstream, as you say, into building housing, which the city and county are permitted to spend on, that directly comes at the expense of providing needed clinical care. In the proposal you'll see, comes by setting aside 80% or more of your new initiative's cancer and women's health budget, potentially for 5 years, and potentially digging up 3 times that amount once institutional pressure and momentum sets in. For me, the biggest problems you run into are mission, metrics, and money. I'm handing out a list of quotes from last week's budget meeting that I think clearly illustrate the 2 hugely different perspectives on who you are and what your goals should be. This is for the benefit of the board members who weren't in attendance for the 4-3 split vote, and for those who approved the committee's recommendation, an opportunity to reflect a bit more on their priorities. I don't want to spend too much time on the actual quotes that I have in this handout, but you'll see there are 2 camps. One is the cost savings perspective of Central Health's mission and this project's metrics for success, and the other is the healthcare services perspective. So I'll let y'all look at that, but in my limited remaining time, I just want to rush through a few issues that come up surrounding the project. One, regarding your mission is not to seek cost savings in healthcare, it's providing healthcare, and I urge you to remember that. And as it was mentioned, Central Health would be the only hospital district attempting this type of project. So I'm curious if you even have an AG opinion that supports Central Health branching out beyond its statutory mission, because the legality of that expenditure should be clarified and a huge concern for all parties, especially when you're negotiating with banks and private investors. So it behooves you to nail that down. And several questions like, will Central Health be providing funds for primary or specialty care for the 250 long-term residents? Integral Care is said to already be providing the actual health support services the project would use, which are limited to mental health. So would that increase? As was said at the meeting, they've even had a disparate project with ECHO providing those services and your same proposed outcomes. So why wouldn't you just fund that and be in compliance with your mission instead of funding an investment vehicle for Bank of America and Goldman Sachs? Oh, I had 3 more pages, but thank you. If there's any questions or if there's any way to best distribute these to the board.
Thank you, Zach.
Thank you. Thank you.
If there are no other citizens' comments,
They would have had to sign up.
okay, all right. All right. So the next will be agenda item 8 on the agenda. The agenda is discussing. Sorry. One.
Tell them what you're
I read it earlier.
Oh, you did, okay,
Yes, you can read it again.
no.
Okay, tonight's agenda will be taken in the following order: 8, 1, 2, 3.
Could you slow down on this?
I'm sorry?
Could you slow down so I can get those?
Sure, no problem. 8, 1, 2, 3. Consent agenda. 5, 4, and 9. Right? All right. Item 8 on the agenda is discuss and take appropriate action on the Central Health owned property, including the downtown campus and adjacent properties. Presenting is Stephen Lamb. So we're going to go into executive session for this item. I announce the board is convening an executive session to discuss agenda item 8 under section 551.072 of the Texas Government Code, deliberation regarding real property, and under section 551.071 of the Texas Government Code, consultation with attorney. Thank y'all.
Yeah, there are different,
Miracle we get out here.
yeah. Yeah, I'd like to do that.
Ready? Okay, it is 6:26, and the board will reconvene in open session. Thank you, everyone. Please have a seat. So we're going on to agenda, item number 1 on the agenda is discuss and take appropriate action on the items related to the Community Care Collaborative. Item A, amendments to the benefit plan for the Travis County residents up to 10% of the federal poverty level who are not enrolled in MAP, and I'll read B afterwards. We're going to have Dr. Mark Hernandez and Kit Smeltz. Thank you.
Ready?
Ready, thank you.
Hi. Good evening. I am Kit Abney Spells. I'm the Senior Director of Eligibility Services. My glasses on so I can read my notes.
And I'll jump in real quick too. I'm Mark Hernandez. I'm the Chief Medical Officer of the Community Care Collaborative.
And if we could be brief, because we're already behind schedule.
Yes.
Thank you.
So the Community Care Collaborative, as you all know, contracts with various clinic systems to provide care to uninsured Travis County residents at or below 200% of the federal poverty level. The clinics are responsible for financially screening their uninsured patients and enrolling them in their own sliding fee scale program. And it's through this process the clinics identify the patients eligible for CCC payment. Clinics are required to send an eligibility file to the CCC with patient's name, patient ID, and demographics in order to receive CCC payment for their services. The Board of Directors for each clinic system is responsible for determining the eligibility criteria of their own sliding fee scale program, and the board also sets the co-pays patients are responsible for when seeking services. Residents can enroll in multiple sliding fee scale programs. Because each sliding fee scale program's criteria varies, the CCC not only receives multiple patient IDs for the same individual, but different demographic information related to income. So I'm going to give you a really brief example how this plays out. So let's take a single parent household with 2 children. The parent earns $2,000 a month from their job and receives $1,200 a month in child support. One clinic system would calculate this monthly household income as $3,200 a month, which equates to roughly 185% of the federal poverty level. A separate clinic system that does not count child support, you know exactly where I'm going, calculates this monthly income at $2,000 a month, which equates to about 25% of the federal poverty level. Clinic systems assess copays based on federal poverty level. So in one clinic system, the family would pay a much higher copay than they would pay in another clinic system. The CCC would then receive 2 eligibility files from the sliding fee scale programs and would have different patient IDs and different FPL levels for the same individual. This creates challenges for the CCC in trying to deduplicate patients in order to get an accurate assessment of the population served through the sliding fee scale programs, and also doing analysis and reporting on the demographics of our sliding fee scale population. So the CCC is proposing to mitigate these challenges by standardizing the eligibility criteria and the copays for the sliding fee scale patients it subsidizes. An additional component of our proposal today is to expand prescription reimbursement to Lone Star Circle of Care, People's Community Clinic, and El Buen Samaritano to their sliding fee scale patients. The CCC currently reimburses community care for their prescription cost, but not these other clinic systems. So this can cause challenges, as you can imagine, for these sliding fee scale patients to access needed medication. The fiscal impact for reimbursing the pharmacy cost for these additional providers is estimated at about $250,000 annually. In summary, standardizing the eligibility criteria and the copays for the population the CCC pays for, and expanding pharmacy payments to Lone Star Pupils in El Buen benefits our patient population and allows the CCC to better manage and the utilization of patients and to collect more accurate data on the population served. Implementation of this proposal will begin in FY19, so the additional pharmacy cost will be built into the CCC FY19 pharmacy budget.
Thank you, Kit. Thank you, Mark. So I'm going to limit discussion to about 10 minutes on this item. And I'm going to go with council's recommendation and ask, is there any questions? Mark, did you have something to say? Mm-hmm. Sorry, Mark. Are there any questions? Cynthia? Or Ron?
No, go ahead, Cynthia.
No, go ahead.
Okay, sorry, all right, I apologize. We're gonna go to, I'm sorry, council, and remind you, she told me something else. My fault. Let's go to B.
Okay.
Maybe
Yeah,
help
sorry, there's two issues.
So, I'm sorry.
We're just gonna get a motion on the floor.
All right, I apologize.
For A before the
I
discussion.
misunderstood, council. So I'd like to entertain a motion before we have a discussion on
A.
this, on A only. Do I hear a motion?
Sir, I move, okay. I move that the board approve and direct Central Health appointees to the Community Care Collaborative Board of Directors to approve an amendment to the benefit plan, which would standardize sliding fee scale program for uninsured Travis County residents at or below 200% of the federal poverty level who are not enrolled in or eligible for the medical access program as presented by staff.
Second.
So, for the record, Dr. Bell read the motion, and Board Member Sherry Greenberg was seconded. Now we can have discussion. I apologize. We're on.
My question is really in terms of the sliding fee scale. Do we know what the current rates are? And people, and those individuals who have access to the, is it covering basic clinical services within their sliding fee scale? Does this cover specialty services, laboratory? So I just want to know, what can they purchase if it's this model?
So each clinic has kind of a different suite of services that it offers. So I'll kind of go to the extremes of that. Community care offers all kinds of things. So they offer specialty care, they offer radiology services, they have in-house lab. There's a lot of things built into the entity known as community care. El Buen is a much smaller operation. They don't offer specialty care in-house. They don't offer mammography, for example, isn't part of the suite of services. And so what you purchase is based on what the clinic provides. And so anything that they provide is covered inside of that sliding fee scale program that clinic offers. That this wouldn't change that. It would just standardize how we calculate how you get on the sliding fee scale and then set the co-pays at a standard across all clinic systems.
And I just want to make one, we are not changing an individual clinic sliding fee scale program. The clinics are mandated by their boards to create a sliding fee scale program. This is creating an eligibility criteria and a prospective, a front-end enrollment for the services that that the CCC provides. So for example, as Mark said, specialty care is not a benefit for sliding fee scale patients today that the CCC pays for. When they would get enrolled in this program, they would get a patient ID, sort of related, and have a standard enrollment. If they seek services at community care that are not paid for by the CCC, they may then enroll in that clinic's sliding fee scale program. So we just have to be very clear, we're not dictating what the clinic sliding fee scale program is. We are standardizing the eligibility program criteria for the services that we provide.
Board Member?
Thank you very much for the information and for what you provided here. I had a long discussion with Mike about this, and it was a little bit different. It wasn't that I was against this or for this. It was, I felt that I would like to have an opportunity to have a full discussion of not only this, but the map redesign amounts and and all of this due, and even the standardization. Mike, can you put the boards together, or the CEOs of the various entities, put them together, and let's see if they can come up with a standardized criteria that they will all agree to. Okay, pretty much what we're telling all the hospitals and care providers, that we'd like the kind of data standardized so that we can actually analyze it better. So that's that was an option. Let's give them an opportunity to do this. But in addition to that, my big concern was that it appeared as if we would then be creating a class of people up to 200% SFS who would be eligible for, I mean, well, not eligible, but, you know, we would be covering, we would be paying for their services in these entities. And I'm sitting here looking at the MAP criteria, which is very different from the up to 200%, because for a family of 3 under MAP, if you didn't have legal status, the monthly income cutoff is $868. $868 for 3 people in MAP right now. And you were talking about on sliding fee scale, you know, for 3 people, you can go up to 2,000 depending, or a little, or 3,000 depending on whose criteria you're using in the other, in El Buen or Peoples or Lone Star Circle of Care. And so what I would have preferred to do, and I was asking whether you would allow us to give us a month to look at having a big discussion, a big picture discussion for the sliding fee scales information and standardization, and then also the MAP, because there are big differences in MAP eligibility, especially for if you don't have the 2+ chronic illnesses, because remember we went up to 150 for that. So I would ask whether or not these things had been considered so that we don't have, so that we have a standardization, where our goal is standardization and leveling up or increasing the number of people that might be eligible for services. You said the cost could impact about 65,000 people. And then and want to hear, you said about 65,000 people might be eligible for SFS under a standardized?
That's based on the numbers that are enrolled, that have utilized, and that the CCC currently pays for.
Right, but
individuals, that would be the estimated number that would be enrolled.
that could be enrolled. And what I'm saying is, like for MAP, we, as a Central Health Board, determined what the MAP eligibility would be. So maybe we, as a board, could change some of those eligibilities so that we would almost have no need for SFS if we looked at SFS and MAP together, go down to 100% or 150%, and look at the possible cost to us for providing those services. And
Cynthia, I think we're getting a little off subject, and so we can probably bring that up to a different board meeting, our committee.
well, the only reason I brought it up is because it seems to me a piecemeal approach to looking at what we originally looked at was how we deliver services, to whom we deliver services, including the MAP redesign, including the integrated model and all this other stuff. And so I would have asked whether you would give us a month to look at having a good discussion on all of this, as opposed to just the standardization of the eligibility criteria for our SFS.
Okay, if there's no further discussion, you want to answer, Mark?
I don't know how quite to answer that question. I don't have the ability to speak to what is on your agenda. So this was the agenda item posted, and this is what we're presenting. If you want to broaden that, that's a board decision, not our decision. So I'm.
And that's the essence of it. So it's really a process matter. And so I think that, you know, given that this is an administrative simplification, program simplification that will help our patients immediately, my recommendation would be to advance this forward. The discussion around whether or not to take MAP eligibility from 6 to 12 months and some of these other issues,
That's right.
it won't be another month. It'll most likely be May, because we would want to have that conversation around, and I'll address this in the CEO's report, by the way, which is, but that would be the likely sequence of this. But again, it's the board's prerogative if they want to consolidate those conversations.
Thank you, Mr. Gibson. Board Member Daniel?
I have a clarifying question. So is your estimated overall impact of this item $250,000 to the CCC?
Because.
It's only for expanded pharmacy benefits, it won't expect other,
Because of the 65,000 or so individuals whom we're referring who would be affected by this program, we are currently paying an encounter rate for those individuals. They are in the sliding fee scale programs of the various clinics, and then we pay. So consolidating them administratively in this program still means that we would pay, and it's money that's already budgeted or would be in our FY19 budget request. So the only new spending here is the pharmacy part for the non-CUC sliding fee scale patients.
thank you.
Seeing no more questions,
Just one.
I'm so sorry, Mr. Jones.
So is the goal of this to make things a lot more consistent across the board? People understand the system?
I think there's a couple of goals. One is definitely create consistency for our patients and for our clinic providers. But the other part of it is it allows us to have much simplified collection of data around these individuals, because they will be in a single file that we keep that allows us to track their utilization in the system as a whole much more efficiently than we can today. I think that's a big plus for us.
Which goes with the model of that the taxpayers particularly have voted for here, is that even though you're in different systems and different people provide them, there's some synergy there.
Yes, sir.
That's what I was trying to make sure that's part of it. Okay, thank you.
Any more questions? Seeing none, we have a motion and a second on the floor. All those in favor say aye.
Aye.
All those against, no. Anyone abstaining?
I'm going to abstain for right now.
All right. All right.
The motion passes.
So motion passes. Let's go to item 1B, amendment to the agreement between the Community Care Collaborative and the Community Care Clinic for the addition of rheumatology and complex primary care services.
All right, you have a memo in front of you. I'm not going to read you the memo because you don't want me to read you the memo, but I'm going to give you a highlight of the memo. We're bringing you this item because anytime the CCC seeks to change a contract with an affiliate of Central Health, and Community Care is an affiliate of Central Health, that actually requires Central Health Board action. It is a reserved power. And so what the CCC is seeking approval is an amendment to CUC's current service contract that would allow us to provide some enhanced reimbursement for two particular services. One is rheumatology, one is complex primary care. Let me quickly explain what we're trying to do in each one of those specialties. In rheumatology, you should be aware that wait lines are long, and that's been a challenging specialty for us. The medium to long-term solution for that is we are recruiting and hiring a new rheumatologist into the area through the medical school and community care, and we expect that those services will be up and running late summer, early fall. However, we would like to do something quicker than that. So towards that end, Community Care has been working with a very esteemed rheumatologist in the community who has worked with the safety net in the past. And that rheumatologist is going to be working with 3 primary care physicians inside of Community Care, 1 position north, 1 central, and 1 south, all whom have volunteered to become quasi-experts in rheumatology under the tutelage of this rheumatologist. And then through the ability of them to access this rheumatologist for conversation and work on patients, these 3 primary care providers will begin to manage rheumatology patients inside of Community Care, dealing with the more simpler new diagnoses, and then also providing ongoing care for people with established rheumatology diagnosis. Particularly by being able to bring patients with established rheumatology diagnosis like rheumatoid arthritis or lupus back into ongoing care inside of Community Care, we decompress the rheumatology clinic so that the rheumatologist can then see more new patients and we get some throughput through the system. Now, in order to be able to facilitate this, those PCPs who are going to be seeing these rheumatology patients, they actually need longer than a standard visit. So it needs to not be a 20-minute visit. It needs to be longer than a 20-minute visit. And that lengthy visit creates a productivity problem for the company, which is being paid based on the number of visits. And so this project could be harmful to Community Care's finances if we just stopped right there. So instead of stopping right there, we are proposing an enhanced reimbursement rate for those particular visits, which will mitigate the risk to Community Care's finances. We do not expect that that is going to create any additional spend. So we're not asking for additional money. It will live inside of the size of Community Care's contract, but it will allow us to reimburse them at an enhanced rate for those sorts of visits. The second part of 1B is we've opened a complex primary care clinic inside of Community Care. It opened on March 1st after being transitioned over from Seton. It's operating. We started with about 90 patients in it, and they are currently recruiting. And that clinic deals with individuals who have both severe chronic illnesses plus problems in the social influencers of health. So those people tend to be individuals who may be homeless, they may have alcohol or drug problems, they may have other issues that impact their ability to maintain their health. This clinic has always been designed with the notion that it provides full wraparound services. So there are social workers and dietitians and various other paraprofessionals inside the clinic, in addition to the physicians and the PAs or nurse practitioners that provide wraparound services. These visits take longer than standard visits. And so whereas we had agreed with Community Care to fund this clinic inside of their typical standard service contract, their regular encounter rate, again, puts them at risk because we know that these patients are going to be scheduled for visits that at a minimum are 30 minutes, and for many of them will be an hour long. And that's the right thing to do, but we don't want to put them at risk for financial issues. And so again, we want to offer them an expanded rate, an enhanced rate for those visits. Again, we're not asking for extra money. We believe this already lives inside of Community Care's budget. And so it doesn't reflect an additional spend, but the amendment is something that you guys have to approve. And so that ends my comments on it. The memo provides more detail. We're requesting approval to amend our FY18 contract with Community Care to include reimbursement for services from the complex primary care clinic and previously for the rheumatology services. And again, no additional funding is required.
Thank you, Dr. Hernandez. I'd like to entertain a motion for discussion. Dr. Bill?
I move that the board approve and direct the Central Health appointees to Community Care Collaborative Board of Directors to approve an amendment to their agreement between Community Care Collaborative and Community Care for addition of rheumatology and complex primary care services as presented by staff.
Very second. Okay. So we have a motion on the floor. Dr. Bell made a motion, and I have a second from Dr. Aiken. Okay. Discussion. Again, I'm going to raise. Go ahead.
I have a quick question. Well, thank you. Just realizing that we have an 8-month wait period. Outrageous. So how long do you anticipate the wait time to be reduced to, given this? And my second part is you have 3 physicians. Would they be located at these 3 different, each clinic will have a physician?
Let me answer your questions in reverse order.
Okay.
Around the physician question, the volunteers that we have are already stationed, one at Southeast, I believe, one is at North Central, I believe, and the other one is in the Central Clinic. I'm going to say Sandra Joy Anderson, and somebody will slap my hands later to tell me I may be wrong.
South Austin, so I'm not
Oh,
sure.
South Austin, okay, my apologies. But, so we've got them kind of stationed where they're already at. And so originally we'll direct patients to the appropriate closest one. If it happens to be in the clinic of origin of the patient, that's fantastic. If it isn't, we will direct them to the clinic that is closest or most convenient geographically for the patient in question. And now I've spoke so much about that, I got to remember what your first question is. Your first
Wait time.
wait time. What do I expect the wait time to go down to? I think with this, at first, we'll be lucky if we can buy maybe 6 weeks to 2 months. off of the wait time. So not as significant as we would like. I think what really begins to break that loose is when we get our second rheumatologist here at the end of the summer, beginning of the fall. The physician is already recruited. We're waiting for them to finish their fellowship and relocate to Austin. I believe they're coming from the Northeast somewhere, some little place called Harvard or something. So they're moving down here to take this job with the medical school and with community care. I think when we get our second rheumatologist, that's when we'll really be able to see a drop, along with the e-consult work that we spoke about in budget and finance. So I think those are the things that finally break this loose. Yes, 8 months, I think you made the comment that that's ridiculous or horrible, or you used some adjective. And it really doesn't matter which one you use, because they're all bad. So I'm not supportive of that either. I think we get a little bit of the way with this first step. I think we get a lot farther with the second step. I think with e-consultation, we finally turn this into a reasonable access, which for me would be at minimum under 60 days. And when we really are rolling, it should be under 30 days. I think.
Let me add, Dr. Hernandez, that's commonplace even in private practice. There aren't enough rheumatologists in town, so a 2-month waiting period to get into rheumatology is uncommon even in my office. So that's reasonable. And if we have the other physicians to help us. Thank you. Any other questions? Board Member Cynthia?
You're welcome.
Thank you. So the patients that are going to be referred to the rheumatology clinics then will be screened?
Yeah, so what will happen at first, Cynthia, is that the rheumatologist that's working with us will work with us and assigned personnel to actually review everybody in the wait list. And they have to be kind of triaged in a couple of ways. Some of those patients will clearly need to see the rheumatologist. Those patients need to get in to see the rheumatologist. Those patients who either have established disease and just need maintenance, or are still in a diagnostic workup but does not seem urgent, those will be patients that will be appropriately triaged to these 3 physicians. When we get the second rheumatologist, then we can really begin to accelerate this. But at first, that's kind of the triaging process that we'll go through.
Since we're already doing that in the other diagnosis.
Exactly, it's the same process.
We're already doing it, this is going to be the same process. So with respect to the entities that are providing some of those additional co-located services or wraparound services, those services are paid for, or the persons that are doing that are people from those specific entities, like mental health or behavioral health. IC has a person there, or who's trained there.
Are you referring about complex primary care?
Yes, complex primary care.
So in the complex primary care clinic that's being operated by community care, everybody in that clinic is actually employed by community care with the following exceptions.
Okay.
So the mental health professional is an employee of Integral Care. If they have because of the arrangement that community care and Integral Care have traditionally had. The physicians are actually employed by the Dell Medical School and are contracted by community care.
The physicians?
They do not work for community care. They are employed by the medical school, and community care contracts with the medical school for their presence in the complex primary care clinic.
And are those the physicians that are paid for by Seton? They're not paid for by us? Or you're saying that they're
They're
paid for
not
by?
paying for them.
Community care is paying for them.
Community care contracts for the physician services.
Are those the doctor residents? No, they're the teachers who would be the physicians?
It could be teachers, though in this particular case they're not.
Okay, so.
Which is to say, I can't speak to whether or not residents or students are placed in the complex primary care clinic.
Okay.
If they were, they would be teachers.
Yeah,
In their absence, they're not.
I would be curious because a professor at a medical school is going to be paid at a much higher rate, I would think, than a regular doctor who's like a last year student ready to enter the arena. And so those are additional costs, or is that?
No, because typically what you do in those cases is you contract for fair market value.
Okay.
What they're getting paid is not necessarily what you pay them.
Okay. And then with respect to the additional funding requests that you say there would not be any additional funds needed for
Because
this year?
for both the rheumatology project that we're speaking of and the complex primary care clinic, community care has, and sorry, let me flip back on my
That's
memo here.
$43,850.
Yeah, so there's a
$43,850,000
contract that we have with community care, and we believe that the additional funds that come from the enhanced rate will live inside of that NTE. So we do not expect to need to come back to this board for permission to use either our own funds or to ask you for your funds in order to augment community care's NTE.
Just a final clarification on the question with respect to the e-consult. As they're doing the review of the case files or the review of the patient's needs to see where it's going to end up getting referred, is there any delineation or any distinction made between a MAP patient and a SFS patient on a regular patient that doesn't make a difference what they are?
God, I'm not sure.
As to how you would, as to how they're being, is one eligible for, let's say if it's a MAP patient, are you going to MAP?
What I would say is through
to
our
e-consult
process,
or
we
doctor?
won't, so we don't pay for patients that aren't MAP or sliding fee scale. So when you say a regular patient, I'm assuming you're talking about commercial Medicare.
Commercial Medicare.
We have nothing to do with those
Okay.
folks. I got
So
nothing to say about
With
them.
SFS and MAP
No,
then?
we draw no distinctions between those patients as we put them through our processes, provided that we've built a process that is meant to service both.
So are you inferring that there are some
I haven't built
places-
them yet, so
Okay.
I haven't built them yet, Cynthia. So when we begin to build them, I'm happy to come back and talk to you guys more about that.
I appreciate that, thank you.
Do I see any other questions? Okay, seeing no other questions, I have a motion on the floor. Dr. Bell made the motion and Dr. Akins said the second. All in favor say aye.
Aye.
All against say no. Anyone abstaining? Motion passes.
Thank you.
All right, thank you, Dr. Bell. Thank you, Dr. Martinez. You're staying on board.
I'm staying on for the next
Staying
item.
on deck, sorry.
I'm letting Kit go.
We enjoy seeing you. Thank you, Kit. All right, item 2 on the agenda is receive and discuss an update from the Community Care Collaborative, presenting Dr. Hernandez, and I'd like to limit it to 5 minutes, Mike. Marcus, we're really behind.
No problem. So I believe that Mike has provided for you in your packet a memo from myself and John Morgan that is titled Item 2, CCC Update on Central Health Fiscal Year 18 Executive Work Plan Activities. On behalf of John, who couldn't be here tonight, and myself, thank you very much for having an executive work plan with these objectives. It wasn't hard at all for us to take the work we do and just stick it into nice, neat categories, which coincides with the way you have thought about how you want to construct healthcare for this. So we've used your structure. So as you look at this memo, you'll see I'm referring to Objective 2, Coordinated System. That's your Objective 2, Coordinated System. And your goal was implement coordinated and patient-focused healthcare system. So we've outlined some strategies in that. Strategy 1, patient wait times. And again, providing you your language. I just want to talk to you briefly. I'm just going to touch highlights. You've read the memo. I'll get out of your way. You can ask me questions. I think that's probably a more useful spending of the time. The main thing around this notion of access for primary and specialty care services is we need data. We've got to be able to understand in full what is the need for primary care and for specialty care, and that means we need our hands on every piece of data that's available. And so towards that, we have been compiling the wait list information. You've heard about that in other meetings of the board. And that list is continuing to be generated with the goal of no longer than a 90-day wait to get to a specialist. That's if it's face-to-face. When we put e-consultation into place, I'm expecting those to actually happen inside of 72 hours. And we will be looking at that as a metric. And then if that converts to face-to-face, that should really happen inside of 90 days, 60 days, 30 days. And so you've heard about the e-consultation solution. I won't belabor that here, but happy to answer questions about it. Strategy 2, patient-reported outcomes and experiences. You want us to establish measures for and improve patient-reported health outcomes. So we're preparing to launch 2 nationally recognized surveys, the Quality of Life Survey and the Patient Experience Survey, using questions from CAHPS, as well as a thing called the Promise tool. So these are national tools. We didn't sit down and write them. We use tools that are nationally accepted, have national ways of being able to assess the data that we receive back. And we're going to be, we've actually begun some of this survey already, some of this work in gathering information through intercept surveys. That's already going on. We've already had the first quarterly MAP patient focus group. So you can gather certain information by sending out questionnaires and calling people and asking them to answer questions. Some information you can only gather by putting people in a room and letting them talk to you. We have proposed that you need to do both if you want to have a good idea of what's going on with folks. And so towards that end, Sarah has championed, and she couldn't be here tonight either. But Sarah has championed for us the notion of patient focus groups. So we've done already our first ones for the first quarter. We'll be doing that quarterly so that we can gather direct information from the mouths of MAP patients to us to augment and support what we get from our survey data. And all of that will get folded into contracting discussions. So as we move into the budget times and we're talking about contracts with our contracted service providers, performance on these tools become part of the contracting discussions and quality measures. Primary and specialty care insured network adequacy. As you know, we've executed work with the Dell Medical School to bring the MSK and the complex gynecology pilots online. We provided you some numbers in this memo, 113 served through complex gynecology thus far, and 355 through the MSK IPU. We started a new ENT clinic at Austin Regional Clinic, and we've added a few additional clinics to create an uptick in the number of patients we're seeing. So far, we've seen 123 patients in that clinic. Perhaps the most impressive part of this is we're running about a 12% no-show rate. That is in contrast to 30 to 35% no-show rates in the standard specialty clinics that we've had. Part of this, I'll have to admit, is because we are scheduling people and seeing them quickly. And we know that the length of time between when you're scheduled for an appointment and when you actually get the appointment is a big driver of no-show rate. And so being able to schedule and quickly get people in, we think is supporting that. We have added a new ophthalmology provider to MAP patients, Eye Physicians of Austin, and 223 patients have been served by this new provider since we've added them to the system. I've already talked to you about rheumatology access, so I'm going to leave that one alone. And we're continuing discussions to add dermatology and pain management, as well as what we've already talked about in rheumatology. Contracting and payment, we continue to monitor our contracts for adherence to value-based provisions, and we'll bring back more information as we gather that. And then moving on into healthcare delivery, so refining the healthcare delivery strategy based on place and people. That is really in conjunction with you guys. Central Health is really the main driver. I would point to Larry Wallace's work and all of the East Side work that's been going on to really broaden the network and offerings to our population. We have been working with you guys in order to bring the one clinic in Jonestown with Lone Star Circle of Care to bear. And so that's probably been our biggest contribution, but I think that work mostly lives focused inside of Central Health. And in the social determinants of health space, which is very important to you guys, we've listed several things that we're doing. We are establishing a food pantry inside of the complex primary care clinic because we see that that's a need for the patients that are served by that particular clinic. And so Sarah's been kind of championing that for us. We're providing information in the MAP eligibility centers about tax preparation to make sure that our patients get their money back because money is so crucially important to our population. And then our Ride Austin pilot is operational. We've given about 400 rides so far. You're going to hear more about that in a meeting coming soon, so no more talk about that because I don't want to steal the thunder. And lastly, we talked about increasing the health program awareness and improvement of enrollment processes. For us, the big news on that is what you guys just did for us, which was to create the program that would allow us to expand the sliding fee scale to 200%. So thank you very much for that, and we'll talk to you more about that. At that point, I'll shut up. I probably took more than 5 minutes, Pete, but...
That's great, Dr. Hernandez, because you are doing what we're here to do, which is take care of our most vulnerable. I mean, those expanding those services is exactly what we told the taxpayers back in 2012, and we're doing it. We're answering their call to help out as many people as we can. And I know that my board members all have great hearts, and so do our taxpayers here in Travis County. And we're doing what they asked us to do, which is take care of them. take care of our homeless, take care of our most vulnerable, our women and children. And you and your staff at Community Care are doing it for us. I mean, we're volunteers. We're here to, just to help you where we can, but you are doing the job. Thank you, Mark. Tell your staff thank you.
I will
With that,
certainly
is
do
there any
that.
questions? We're gonna try to catch a tailwind here, and I'm gonna give people maybe 10 minutes for discussion. So, Maram. Yes, sir.
Okay, well, mine is really brief. Thank you so much. This is very helpful. It's actually more of a comment than a question. So, if the medical school was not in existence, what would have happened to our musculoskeletal patients and the complex gynecology? How would have the wait list look like? And so just if you can elaborate on the value.
In musculoskeletal, I fear that we would still have lengthy wait times. If you recall, wait times for musculoskeletal were certainly greater than 9 months, and in some cases out to a year. Prior to the onset of the original musculoskeletal pilot and now the operation of the IPU, I don't know that we would have been able to create the change in practice that allowed us to really work down that line and create better efficiency for our patients. And so I think that's directly related to the medical school's appearance on the scene. In the complex gynecology area, that's an interesting question, because I think if you consider the specific diagnoses that are being managed in the complex gynecology clinic, those diagnoses were being managed through a variety of places in the system because they weren't necessarily well recognized, well diagnosed, and dealt with. And so, a woman who might have been having pelvic disease was probably bouncing around between primary care doctor to emergency room to surgeon to various people trying to get a real diagnosis. And so you might not have found a discrete line. What you would have found is a lot of women not getting their problems addressed in real time. It would have been hard to find the line of those because we weren't treating it as a service line that needed its own wraparound set of services. I think that's what the medical school brought, was the notion that there are a set of diseases inside of the gynecology space that actually require a team approach, and we have to talk about it out loud, aggregate the women who actually have that issue, and get them into line and into care. I think that's the value of what's happened here. I think it'll become more evident as we move forward when we see how many women actually get treatment and actually improve. So I think the patient-reported outcome measures that come out of that clinic are going to be crucial in proving up the value of that clinic. The true improvement in the lives of these women is what we're going to point at as, this is why you always needed this. You didn't have it before, and therefore you didn't recognize these women and the suffering that was going on because it was disseminated across the system. That's how I would answer you.
Board Member Valdez?
So the last question last comments that I was making in the previous item, I can see how they had everything to do with item number 2, which is what we were discussing here. And that's where they would fall in line. So with respect to the ability, you'd be able to, your ability would then extend to being able to see how patients are actually referred. There's, I'm assuming, a process that would be developed.
You're talking about?
Yes, all the new patients that are those that are on the wait list, some that are very old patients that have yet to be seen or haven't necessarily dropped off because they haven't been contacted. So those patients then would have had an opportunity to be referred, and someone is going to keep track of whether or not they're
and the first thing
the
first thing that we do with all of these specialty service line projects is to call everybody. So I've got 4 staff members who spend a fairly large amount of their professional life reaching out to patients and finding out, hey, are you still here?
Right.
Talk to us about your problem. Have you sought care elsewhere? Have you resolved your problem? No, you haven't. Okay, well, let's make sure and reaffirm your place in line. And we're beginning these services. Let's get you scheduled. So that's the first thing we do in all of these.
And then with respect to the surveys that are being conducted, and you said you've already had a patient focus group that's already met, Are these reflective of the population that you're serving?
Yeah, and we're gonna be back to talk to you more about all of that. Sarah is really have been front and center. The first set of patient focus groups we did in bilingual now, I will tell you, we did sets of English and sets of Spanish. We did not go to, other.
Languages?
And that needs to be a focus, so we readily admit that that is not fully reflective of the population. It is certainly reflective of a majority of the population, and yet that minority of the population is important as well, and we'll need to make sure we extend to the Asian community, for example, that may have language challenges as well. We're gonna need to be able to expand to those populations as well.
And that could happen when we have staff on board that are from those populations, correct?
Certainly.
Okay, and so then, with respect to the systems designs, those are all being lumped together. When you talk to us about integrated delivery system and someone else talks to us about integrated delivery system, that's really being done under the auspices of the umbrella of you, the CCC,
That's
correct? Okay, and with respect to the social determinants, how we're addressing those by those individually located persons or entities representing their agencies on those, I guess, in those clinics, then we're providing the space for them, and they are coming in, and is it every day or sometimes a
So
week?
that has certainly been the model. Now, Community Care is probably the organization I would point out that has maximized that. So, and we pick on Southeast Health and Wellness Center a lot, but it was specifically built to be able to do that, to have purposeful space inside of the building so that you could have other agencies involved. But I think we've also learned a lot of lessons from the success of that particular facility. And so I know that Larry and others, as we are looking at what we are trying to do on the east side, are trying to take lessons learned from our last big clinic project, which was Southeast Health and Wellness Center. And Sandra Day Anderson learned some things from Southeast Health and Wellness Center. We have to keep learning from each experience we have. Southeast Health and Wellness Center clearly was you could raise that up in the community as the right way to have done it.
I know, thank you.
As you're familiar with. And so those opportunities can't be lost as we continue to expand.
And then one last thing for trying to reach out to those consumers or patients who only may come in once a year, or just for the wellness check or however, and if they may not necessarily be in that digital world, rather outside that digital world, you all have strategies for reaching out to them also?
Yeah, and we need to learn to scale those strategies. So where I say those strategies live mostly right now is in the CCC proper. So I have one piece of the CCC that is touching patients. It's our medical management department. And it is probably unique to our operation, and I don't know whether or not Community Care's complex primary care clinic is going to configure itself that way, but we do home visits. We go out to where the patient is, and when I say home visits, I mean, what do you call home? If home for you is Cesar Chavez and 35, then that's where we go see you. If home is in a skilled nursing facility, then that's where we go see you. If home is your apartment over on the east side of Austin, then that's where we go. And so we have extended ourselves into the environment where our patients are. We will have to scale those sorts of solutions even as we continue to expand digital touches because of I will say it out loud, cost containment. So I do believe that cost containment is an important part of our job, but for this reason. I want to make sure that every dollar we spend is spent in a way that is respectful of the health outcomes that we're trying to create. And so if we can do something efficiently, which is to say not spending more money than we have to through a digital platform, then that saves dollars so that we can pay a nurse to go out to somebody's home when that's the only way you're really going to help that patient. You got to save money for those more expensive ways to reach out to people, and that is created by being efficient in those places where efficiency doesn't affect the outcome.
And so that's also being done on a comparative basis, so when they finally come in, they're comparing to the previous visit to know whether the quality of life is actually being improved.
Correct.
Okay, thank you.
Thank you, Board Member. Do I hear see any other questions?
I just want to compliment you and encourage you to continue to support the work that Larry is doing on the Eastern Crescent in terms of services out there.
As soon as he gets them all built, we'll be out there
All right, board,
Force.
this is an information item, so we
Thank you,
don't
Dr.
we don't
Hernandez.
have any action. I'm gonna request a 5-minute recess. If you'd like to get some food, you can grab some food next door, but I'd like to start back at 7:20. Let's catch a tailwind.
Thank you.
All right. Do I need to?
Yeah, we don't want the chair hungry, we want the chair happy.
Oh, he's not ready yet.
Ready? Okay. 7:25, we're going to come back into regular session. All right, next is item number 3 on the agenda is receive and discuss the Central Health Performance Review conduct by Germain Solutions by Mr. Eastman.
Yes, thank you, Mr. Chair. Members, Mr. Burton had actually addressed most of this issue in citizens' communications, but the key takeaway is that we are having community outreach sessions around the Germain Solutions report, and this will inform our strategic plan. We will bring this back through committee and ultimately to the full board, being the management recommendations with community input so that you can make a decision. I'm happy to answer any questions that are in the memo that's in your packet.
Not set for question.
Oh, I'm sorry, excuse me, it's just an update.
It's just an update. All right. The next agenda item is the consent agenda. C1, approve minutes for the following meeting of the Central Health Board of Managers, February 28th, 2018, March 19th, 2018. C2, receive a report of the February 2018 financial statements for Central Health as presented to the Budget and Finance Committee. C3, receive a report of the January 2018 financial statements for the Community Care Collaboratives as presented to the Budget and Finance Committee. C4, receive the quarterly investment report and ratify Central Health investments for February 2018. C5, approve and direct the Central Health appointees to the Community Care Collaborative, the CCC, Board of Directors to approve a contract between the Community Care Collaborative and Fibroblasts for specialty care referral management in an amount not to exceed $700,000 as recommended by Budget and Finance Committee. And C6, approve the commitment of $400,000 of new initiative funds to Ending Homelessness Coalition's Permanent Support Housing Project expected to reduce emergency department visits and hospitalization rates among homeless Travis County residents as recommended by the Budget and Finance Committee. All these are coming from committee, so they don't need a second. We can move on with the consent agenda as a group, unless I hear something else. Board Member Valdez.
Well, I'll make a motion to approve items, consent items C1 through C5, and then make C6 a separate issue.
Okay, so do you want to pull C6?
Pull C6.
Okay. All right. Board Member Valdez requests to pull consent item C6.
I'll second.
Do we need a second?
Well, she also made the motion to approve.
C1 through C5, yeah.
Can
I
we vote on
second
that?
Okay.
C1 through C5.
Okay. Do I hear any discussion on C1 through C5?
There's no discussion.
There's no
on
discussion.
it.
All right. All in favor say aye.
Aye.
All against say no. All abstain. Anyone abstaining? Okay. All right. The motion carries. All right. So now you're going to pull C6. Does she need a second for that?
So just read the item out again,
All right.
and we can have discussion on C6.
All right. C6, approve the commitment of $400,000 of new initiative funds to the Ending Homeless Coalition's Permanent Supportive Housing Project, expected to reduce emergency department visits and hospitalization rates among homeless Travis County residents as recommended by the Budget and Finance Committee. Now, do we have a question?
Yes.
From?
Can I ask a procedural question real quick? Can we get a motion on the table before we have any discussion?
Sure. I agree to that, sorry. Can I hear a motion to approve C6?
Yeah, I'm happy to make that motion.
Is that what in a second?
Oh, yeah. With the board commit $400,000 of new initiative funds to the Ending Community Homelessness Coalition's Permanent Supportive Housing Project, expected to reduce emergency department visits and hospitalization rates among homeless Travis County residents, contingent upon the board's review and approval of the final contract terms. Is that going to come back to the board, or wouldn't we delegate that to the executive director to negotiate terms?
Go through the motion.
Well, I'm asking a question about the motion. So I'm suggesting that rather than the contract come back to the board, that we approve the expenditure and let the executive director negotiate on terms similar to or more favorable than we adopt today.
So the recommendation was, again, on the funding amount, as you see, but then we would actually go negotiate. There's not any preliminary terms put forward before the board, and so we would have to go negotiate those terms. And based on the recommendation at the Budget and Finance Committee, we would bring those back to the board for then full consideration of the terms as well as the dollar amount.
Have we not typically, once we've approved a dollar amount like this, allowed the executive director to enter into negotiations?
So it can go either way, but I think that the committee expressed last week that they would like to see the terms and the outcome measures that were negotiated before the contract was actually executed. And it was also expressed as a commitment, not authorizing an expenditure.
Okay, well, I'll make the motion as it's stated here, but I would just say that, you know, we have a lot of business before us, and typically, once we express our intent, it's really staff's job to go and execute it and carry it out, so that we're not discussing something that was discussed at Budget and Finance, now at a board meeting, now it's gonna come back again, so. But I hear you, I hear the discussion from
Oh, will you make the motion?
Budget and Finance, so yeah, I'll finish that up. So I move that the board commit $400,000 of new initiative funds to the Ending Community Homelessness Coalition's Permanent Supportive Housing Project, expected to reduce emergency department visits and hospitalization rates among homeless Travis County residents, contingent upon the board's review and approval of the final contract terms and outcome measures to be achieved.
Second.
So for the record, Board Member Daniels made the motion, and Board Member Jones did the second. Is there any discussion? Board Member Valdez. Ram.
Well, if I may read a statement.
You read a statement.
More clarification of my position and where I stand in this issue. Well, dear community members, fellow Central Health Board members, executives, and CEO, I wholeheartedly believe we cannot improve health outcomes without addressing daily, long-term factors impacting our lives. Health outcomes and quality of life are governed by social determinants of health, including where we live, work, and play. We ought to address the inequities in our community, the people we are here to serve. It disheartens me to learn of the health disparities our community suffers due to inequities in education, social structures, livelihood opportunities, etc. Childhood poverty in Travis County continues to rise. There has been slight improvements compared to last year. In 2018, for each Black and Hispanic child, it's 33%. Our health ranking per Robert Wood Johnson Foundation has not shown much improvement. In 2012, we ranked 8th among other counties in Texas, and in 2018, we're still number 8. For the money spent on health care, since we have not shown much achievement to the targeted for health outcomes, our community needs expand beyond the clinical walls. Our communities need affordable housing, food security, economic stability, education, transportation, and much more. We will not achieve improved health without addressing the basic needs to live as vibrant and productive individuals. Schools are closing in East Austin due to inequities which lead to poor academic performance. That is health. Can you imagine what the future may hold for those students? I will do everything I can to shape, create, and advocate for our community needs. I will do what is right, ethically sound, and what my heart and mind determines as just. I am very persistent. I know we must address homelessness in Austin, Travis County. It's unacceptable that many chronic homeless individuals seek emergency care for their basic human needs and care, such as food and shelter. These high ER utilizers are extremely costly to our taxpayers, and yet their health outcomes are poor and will continue seeking ER services. Yet, it's no-brainer to support homelessness initiatives. especially to a public health professional. But given the current circumstances, the financial strains and obligations, I cannot support any social service funding without having collaborative strategy with our city, county officials, and partners. I will not accept a Band-Aid solution. I want to see actionable steps in addressing social determinants of health and not just becoming a buzzword. It must be embedded in Central Health's DNA and in every partner and provider we partner with. This is what I believe is right. I went into public health after I witnessed many of my patients dying and having poor health outcomes due to hunger, homelessness, lack of transportation, and special empathy in care. I believe it is the time to bridge both clinical care and public health. You may think what I'm asking for is far-fetched, and we do not live in a perfect world. I see us as change agents, as the voice for those who need us, as superheroes. In our performance review by Germain Solutions, they could not find a comparable hospital district like us. After much thought, I see it as an opportunity to rethink how we deliver care and to be a model for other counties and for the nation to witness a model healthy county and city. We have the tools, passion, and dedication to drive change. My hopes are we are able to have a dedicated funding for social services in our next fiscal budget to better serve our community needs. Dear Anne and ECHO board and executives, I commend you on all your efforts in ending homelessness. I share your passion and aspiration. Unfortunately, with what I just outlined, I cannot support it at this given time. Thank you.
Board Member Valdez?
I echo Board Member Maram's comments in that, and also just wanted to add and clarify that we do have a city housing, HACA, Housing Authority for the City of Austin. We have the county housing authority. We have elected officials of the city and the county that have created entities that are supposed to address the issues of homelessness, affordability, and making sure that our families and our children have places to live and shelter so that they can stabilize their lives and participate and improve their quality of life through all the other determinants of health and the determinants of life. I do believe that there has been an audit conducted by the City of Austin, and the entity that the concern that they had was that there appeared to be some deficiencies in the funding of programs that were receiving monies to address specific issues in dealing with public health and dealing with social determinants.
Okay.
And
Hold on, Board Member.
And as
I'm gonna look over to council about what we should do here.
Getting a little bit off topic about
Sorry,
monies
Board Member.
being given to other programs related to homelessness. We're discussing this program that pay for success.
I am specifically addressing this, Nicole.
Well,
Okay, thank
I'm
you.
just-
Should we go into
I'm just
executive session,
trying to
council?
get you, make sure that you're aware of the agenda item.
No, I know what the agenda item, it clearly have spoken to it. I spoke to it at the last board meeting, at Budget and Finance, and I have expressed my concerns to anybody that would listen. I do believe that there needs to be a comprehensive strategy put in place, and that Central Health needs to dedicate its dollars to the provision of a healthcare services delivery system and to direct services for those which we were entrusted to do, and that was by statute and by law, and that is the indigent, the homeless, and those people who
Why
need
don't we,
help.
why don't
So-
we take this into executive session?
So with respect to that, I don't believe that it's appropriate for us to spend our dollars on anything other than healthcare services delivery
I'm going to
system.
stop you because I think if we want to discuss this further, specifically statutory obligations and healthcare services delivery and what we spend
No, ma'am.
funds
I'm
on, we're going
referring-
to go
I'm-
into executive session for that.
Okay, well, I'm making a comment about this particular item on the agenda. This item on the agenda is an entity, is
Okay.
a request
Go
to
ahead.
deal
I'm gonna
with.
call for executive session.
Okay.
Sorry. I apologize, Cynthia,
That's okay.
but we have to do this. All right, sorry.
Under section,
All right. I announce the board is convening an executive session to discuss agenda item The consent agenda item 6, under section, under section 551.071 of the Texas Government Code, consultation with attorney. So can we, the time is 7:40. It is 8:05. We're coming out of executive session into regular open session.
May I finish my statement? I'll start over. Basic, it's going to be very fast, very quick.
Can you read just the agenda item that,
Okay.
that we're
And
we're
then go back
on?
and discuss C6, agenda item C6, which is approve the commitment of $400,000 of new initiative funds to the Ending Homelessness Coalition Permanent Supportive Housing Project, expected to reduce emergency room department visits and hospitalization rates among homeless Travis County residents as recommended by Budget and Finance Committee. Board Member Valdez.
Okay, with respect to this particular agenda item, I cannot support the initiative at this time because I believe that all our money needs to be directed to medical and hospital care for our district's needy inhabitants. And anything outside of direct services is not anything that I can entertain right now, especially in light of the fact that we have a lot of financial needs and other issues with respect to Central Health and our needy that must be addressed. And at some point in time, we as a board and a community should have an open discussion about, with all our governing bodies, governmental bodies, as to what our strategies will be to cure the ills that impact the quality of life that we have here in Travis County, including housing, lack of jobs, et cetera, et cetera. So,
Thank you, Board Member Valdez. I'm going to recognize Mr. Giesman again.
Yes, so to talk about the process around working through this contract, we will, obviously, if this is, motion is approved, then we will begin working through specific terms and addressing a number of issues that were raised at the last meeting, as well as the statements that were read earlier. And looking at who are the investors and what is it that they are earning, what are the expectations around this, looking at how do we define some of the outcomes around reducing ER utilization, for instance. Where is the housing going to be located, and who will have ownership of that housing? So I didn't want to get into trying to negotiate and perfect all these terms, not knowing if the board was committed to a certain level of funding. And so, again, if this moves forward, then we're going to continue to negotiate that. But at the end of the day, we're going to bring this back to you again so that you can see it and discuss it, and then ultimately it'll be voted on and discussed in an open session if you will have the chance to consult with legal counsel in closed session. So that's just an overview of the process, and we'll work expeditiously should you all approve this to address many of the concerns that were raised here this evening at the last meeting, at the Budget and Finance meeting as well.
Thank you, Mr. Eastman. Board Member Katrina Daniel.
I have a quick question. The original request was for $1.2 million, is that right?
Yes.
Is there, I understood from the last discussion in the Budget and Finance Committee meeting and maybe even conversations that happened since then, is there an effort underway or any opportunity to bridge that gap, the $800,000 gap between the original $1.2 million request and the $400,000 that Central Health itself, out of its own Central Health funds, is committing with this vote?
Yes, the short answer is yes. There is something under, we've begun some initial cursory conversations, but if this passes, then we will step that up to be able to close that gap.
So perhaps maybe not directly from Central Health funds, but through efforts in conjunction with Central Health, we may be able to help bridge that.
With our
gap for the
partners.
full
With our
funds.
partners.
Okay.
Yes.
Okay. Thank you.
Any other questions? Ms. Jones.
I just want to emphasize that I understand this is a pilot model we're looking at. This is part of the partnership, so it's not just us ourselves. We're partnering with our colleagues, the city and the county. I do think, though, that this has taught us the lesson. As we look at these type of projects, we need to strategically look at a long-term to address these disparate issues that we see in our community. I think this is an opportunity to elevate that effort, to begin to look at what strategies we can incorporate so that we won't find ourselves here 6 months or a year from now saying, here's another pilot that we need to look at without a framework in which to target it in. So I'd encourage us to consider that as we.
Board Member.
Yes, so I wholeheartedly concur with that, and on the agenda that will be posted for the next meeting of the Strategic Planning Committee, you will see that very item.
Thank you.
Any other questions? Okay, I have a motion on the floor. Board Member Daniel made the motion, and I think it was Board Member Jones seconded. All in favor, say aye.
Aye.
Aye. All against, say no.
No.
So we have 2 noes. Anyone abstaining? Okay, so motion carries. So we'll ask our CEO and executive management team to go ahead and proceed. All right, thank you. All right, item 5 is to receive and discuss a report from the President and CEO of Central Health Operations and current activities, including the fiscal year 2018 Central Health Board of Managers Work Plan and operational priorities. B, an assessment of systems and processes. C, the Central Health Organization chart and other personal matters. Mr. Beasley, we have 15 minutes allotted, but I'm going to ask you to try to do it in 5.
All
Sorry,
right, very good, thank you. So I will limit my comments to item A, fiscal year 2018 Central Health Board of Managers Work Plan and operational priorities. So as we mentioned on prior occasions, we are working towards redefining our strategic plan and aligning that with our budget. And that will have to come before the county commission, become before this body, before the county commissioners court this summer. So we're working with 3 operational objectives, and you'll hear me repeat them often because I think it's important for organizations to stay disciplined and focused on what it is that they're trying to achieve. So refining the healthcare delivery strategy based on place and people. We also refer to this as the geography of health. Implement coordinated and patient-focused healthcare system, and implement a sustainable financial model that supports the first 2, the delivery strategy as well as the system strategies for a patient-focused healthcare system. As mentioned earlier, we're currently out in the community and we're seeking input on the Germain Performance Review, and that will inform the strategic planning process as we align that with the budget development process. So here's what we're going to be asking of the board over the next couple of months. This evening, you've already heard from the CCC, a very high-level overview of how it's contributing to the strategies. This isn't a future hope. This is real action now that's happening, that people are feeling in their lives. Next month, you'll hear from Mr. Wallace, and he'll talk about the ongoing work in the Eastern Crescent with his Eastern Travis County Working Group, which is taking great strides in many areas. And you've already seen the most recent one in Elroy, where we're co-locating with the fire station and working with the UT School of Nursing. There's more updates similar to that. You're getting the email updates on that. But also, Mr. Wallace will begin to look forward, taking the demographic report as the basis and saying, okay, in the areas where we need to be, what will the strategies look like? And he'll start to shape that discussion. Also in the April board meeting, possibly a retreat that we're trying to plan. Again, the date is to be determined, and that'll be posted as well. We'll begin setting the stage for key discussions that will come up in May. Some of those discussions are, we'll discuss what's happening with the lawsuit. We'll talk about service level reports, who we've served and what type of care they've received, and answering very basic questions about what it is that we're doing for the residents of Travis County who are low income and uninsured. We will be receiving briefing on the assumptions underlying the budget and start to receive guidance and feedback from you as to what the priorities are as they align with the strategic work plan that we're putting together. We'll talk about hospital service level reporting, and we will probably have conversations around Brackenridge as well. In May, we will hear from the community care healthcare centers, and this is part 2 of the discussion that Larry is going to tee up in April, but he will lay out the construct for what our healthcare delivery strategy looks like in Travis County. But then you'll hear directly from our largest clinical partner, who provides primary and specialty care services, to what it is that they will need to be able to serve not just today, but in years from now, and be in the right places with the right type of care. We'll have a discussion ultimately leading to a decision regarding what our funding partnership with Seton looks like for the safety net population. And we'll look at the different funding models that are possibilities, including all the regulatory issues that surround them, and as well, and that includes intergovernmental transfers and how those are utilized. Also in May, this is when we will be bringing final decisions on what the strategic plan looks like based on what the performance review input is. That'll come through committee, up through the board. Then you'll have on the budget piece, again, we're bringing those together, some, what I would say preliminary staff recommendations, but there's still a lot that and I'm skipping over a lot of details, but there's still some that we'll have to go through, but we anticipate the draft budget, I guess, by June. But you'll be able to see some preliminary staff recommendations starting in May. So with that, I'll pause there. I don't have any other comments to add. I just wanted to take all of these things that you've been hearing about and reading about and try to pull it all together and what the work looks like for the next couple of months.
And as your board chair, I've directed staff, as Mike has alluded to coordinate at least a retreat for this board so we could get together and see each other's thoughts and opinions. And so I've asked Ms. Ferris to send out emails. So please be responsive to those emails of when you can come to a retreat. It would probably be a Saturday, either in April or May, from about noon to 12, from 9 until 12, and to be a place to be determined. But please respond to Ms. Ferris. And as Mike has alluded to too, is we may have some extra meetings we may need to bring to get us together. That we'll probably be here unless you say something different.
Probably be here.
Yeah, maybe over a lunch hour, but let Ms. Ferris know. Thanks, Emily, for doing that. But the staff has been directed to go ahead and do those things so we can prepare for our budget, because it's always hard to get through that budget. And Board Member Daniels knows how hard it is. She's chaired us and has led us through the dark and to the light. But I really do thank everybody for being here. And again, I've told Maram this many times. I'm every one of y'all's #1 fan. I see what's in your hearts. I see what's in your minds, and it's all about taking care of those who we need to take care of. I love every one of y'all for doing what you do. With that, item 4.
Can I ask a
Yes, sir.
question?
Yes, sir.
You've done a great job in helping to bring this together.
I'm trying.
I think it's important, particularly as one who's lived in another county where there was a hospital district that operated completely different than this. I think we have a responsibility to help the citizens of this community understand the system under which we operate. Because most people in urban centers of Texas are accustomed to a hospital district that is the provider of service, that is the site of services that they refer to. Our system is completely different.
Right.
And I don't think many of the taxpayers, I don't know what percent, but a large number don't understand that. So I think part of the effort you're undertaking is to help them to understand that we have a collaborative system in which we contract out, we don't provide. And I think that's important for them to understand that, because I think a lot of people don't understand what Central Health, that model, how that operates here. So to the degree that we can do a lot more that I would encourage.
Yes. I remember respond to that, Mr. Jones. When this man came for the interview with us before we hired him, I fell in love with this one comment. He was going to have end of the driveway discussions.
That's right.
Which made perfect sense to me that he was going to be out there in the public discussing with whoever wanted to discuss it with him, being more visible, being more transparent. And that's why I fell in love with him when I heard him talk, because that made sense. We have to be out there with Board Member Greenberg.
Yes.
Sorry.
And to add to that, prior to when you were, and thank you for serving on this board, appointed the board committed to an education initiative.
Right. Campaign.
For exactly the reasons that you were explaining. Mr. Burton has been so on top of that, and I know at strategic planning we'll be discussing more about that and the results that are really wonderful that we've seen from that. But it is for those very reasons that the board committed to that education initiative, and we'll be talking more about that.
And your comments are duly noted, and this is that's part of our community conversations that we're having around the performance review.
That's right.
Are designed to address those very issues. What is it that we do? How do we do it? And who do we serve. And the performance review pointed out that, yes, we do have this partnership model, and there's pluses and minuses to that, and that's part of the discussion in this. But I think all of those issues are going to come right back to this board with, here's some strategies to be able to either clarify this, but also, I mean, Ted's taken it up several notches from where we were in terms of the outreach, but how to go even higher on this, because we want everybody, whether it's in this room or a person who's waiting at a bus stop in Dove Springs, to know exactly what we do and how we do it.
Well,
I
I've seen-
appreciate what you're saying.
No, I've seen the work that they produce, particularly on the media pieces on TV and some of the outreach efforts. But I just think it's important that we inculcate that into everything we do in
Yes,
terms
sir.
of messaging.
There's still an understanding gap we got to
Yes,
close.
yes.
I completely agree with you.
And it's an ongoing effort that we are very cognizant of, yes.
Thank you for putting that forward.
And again, I also have to commend Ted for all the work he does and all his staff to get us out there in social media, get everybody to understand what we're doing. All right, thank you. All right, agenda item 4, the agenda is receive and discuss reports from board of committees, budget and finance. Dr. Bell.
2 minutes.
You're
We pretty
wonderful.
much rehashed everything that we did in budget, so Budget and Finance Committee, so you guys sort of know what went on. But I do want to remind the members that we will have a very important discussion at our next board meeting with regard to the homestead exemption. That issue has a lot of facets that we need to put on the table and talk about and discuss. You had information with regard to that in your packet that was sent last week. We postponed that item for next budget meeting, okay? So please come ready to discuss. I'd like to have a very robust discussion, but I'd also like to have a very efficient discussion, okay? That's it, sir.
Thank you, Dr. Bell. All right, item 9 on the agenda is confirm the next regular board meeting date, time, and location. The next Central Board, Health Board of Managers meeting is scheduled on April 25th, 2018 at 5:30 PM at Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. And with that, I'll entertain.
Move adjournment.
Okay, second. All in favor, say
Aye.
aye. Wow. Thank you, board. Y'all are fantastic. Thank you, board members.
They have.